Hello, everyone. Thank you very, very much for waiting. And I want to give a very warm welcome today on behalf of the Association for Medical and Healthcare Humanities. And as well as that, just to say that we've got a very interesting evening ahead of us that we hope will spark lots of discussion, some questions, but also some discussion. And if there's something that comes up as as the presentations go on, just put some points in the chat or anything like that, because we'll come back to the chat at the end of everything for taking questions and making that discussion. Very, very quickly, this is one of several different events that will be happening throughout the year. To mark the fact that the membership of the AMH voted to become the Association for Medical and Healthcare Humanities at the end of last year. And this, for all of us, is about supporting a range of diversity. Diversity in terms of practitioners of different types of healthcare, a recognition that, we've always, anyway, at the AMH had some nurses, some radiographers, people from different disciplines, and also from healthcare systems other than biomedicine, but also to think much, much more about inclusivity, in fact, in all of its forms. And so with that, with no further ado, I'd like to welcome you again and pass you over to Carlos. Carlos and Rada have created this evening for us this marvelous seminar.
Thank you very much. And this is a very good opportunity. So I hope and we hope that people will enjoy the program that we put together for tonight. I am going to open a presentation just to remind people of some basic points and give a bit of context about the night. Jennifer, you know a bit about the program. Can you say something while I do this?
Right.
Probably, I think that the most important thing is about Leonore, that she will not be with us tonight. And we have a video that she has shared with us. Would you like to say something about that?
I have watched the video and participated in it. Will be in Spanish with English subtitles. And I think that it's Leonore's a really extraordinary woman who is actually Colombian ambassador to the United Nations, and she is the first person from an indigenous background to reach such an incredibly high office. And the video is a very thoughtful, to the point. She's made it specially for this evening. A very thoughtful and considered discussion about what health and healthcare, and indeed medicine as such, means within her own context and within the context of the indigenous peoples that she represents. And I think I think you'll find it quite surprising. Some of it you will find perhaps not so surprising, but some of it there is an emphasis throughout that I think is quite surprising, something that we don't often think about, which is about the importance of place for mending health, for retaining health. How are you getting on,
Joe?
Carl?
Yes, I send it. I send it to everybody in the council. So I think any person in the council can open it.
The other thing that I would just tell everybody while this is going on in the background is that unfortunately James Wade, who is our poet, is unable to be with us this evening. He's in bed with a fever. And so we have another Carlos has stepped in with a project, which is a palliative care project that he ran, which you will see further on in this evening's presentations.
Thank you, Joe. And if you can kindly put it in the
Sure.
slide show.
All right. You just
Yes.
tell me when you want me to move,
Yes.
Carlos.
Thank you very much, and I am sorry for this. We took 2 hours this afternoon to prepare everything, but that happens when we prepare. I'm so sorry about this. Anyway, the aims for today, for tonight, and for the association in the mid and long term. Can you next? Thank you. It's our interest to continue demonstrating how the humanities benefit and enrich our worldview about needs of good health care. As we explain in the abstract and invitation to this program tonight, something that we are exploring further now is healthcare. We are very much interested in healthcare and how medical humanities can contribute to that. Next. We expect, the association expects that we will contribute to the discourse that medical sciences would benefit from integrating further the cultural, and I think that tonight is a very cultural night, the psychosocial, the spiritual, the artistic, the political, and economic perspectives to enrich our worldview when it comes to issues of health, disease, illness, and care. Something that I was thinking while I was doing this presentation is that in many cases, in my case, when I do my research, I always try to take care of the cultural, the psychosocial, but I was thinking that sometimes I don't include the political at front as well, and that I sometimes, even the economic, I don't understand economic issues, although I understand issues about health and disease and care. So I think this is something that we are very much interested in, how to integrate and integrate further and how to think politically. I think that we are in a historical moment that is very important for us to think politically about health, illness, and culture. Next. And the third point, integrating further, because it's not that we are not doing it, we are doing it, but I think that the invitation and this moment of changing the name of the association to include healthcare is with this purpose, that we can integrate further so that we can understand the daily world of the stakeholders, how they operate. And by stakeholders, we mean the clinicians, the patients, the practitioners, the students, the academics. I think that it's our interest to bring all these stakeholders together. And the invitation is the daily life. I think we want to address that daily life is important because just to mention an example of what is going on in the UK, I think that the people that are delivering the health services that are in the front lines are the ones that are experiencing many of the tensions that we can see in the system, and we cannot ignore that. I think that we need to give more importance and significance in our projects and in our research to these issues. Next. We also thought that it will be very important just to mention some points about tonight. And the first one, yes, next, is regarding indigenous people. As Jennifer kindly already said, when we were thinking about this program, we thought that it would be very interesting to have a very cultural program for tonight. And then through my work in Colombia some years ago, I came across the Arhuaco community in Colombia. And it has been historically very significant that the first indigenous woman has been selected to represent Colombia as the ambassador in New York in the United Nations. And I think, I don't know how many of you are familiar, but Latin America is going into a very political and historical significant moment, I think that Brazil also now is selecting indigenous women to represent and in positions of high power. So it's a very interesting moment. And tonight is unfortunately that we couldn't have her because her agenda was very busy. But in a kind way, she decided to do a recording for us. And we have worked to, offer you tonight a very excellent video. And that we are going to share with you all in some minutes. Poetry, as also Jennifer already mentioned, James Waite is a colleague at the University of Greenwich in administration. And why we decided to involve him was because in a project that I was running about palliative care, in some of the moments that we felt that the tensions to talk about death and dying, when you are talking about these issues, they raise a lot of emotions, a lot of feelings. So we decided to invite a poet so that he could write probably some poetry while we were doing the research. And in some of the public engagement events, so he was reading the poems, and we realized that that was quite powerful. So we are going to give you a glimpse about the poetry, because as we said, James unfortunately is not well. The next point, yes, it's about health systems as social institutions and how these social institutions reflect the societies in which we live. And of course, two examples tonight will be Radha, that in some minutes is going to share with us a piece that she has written about, she has written about the UK with some of the criticisms to understand what is going on with the NHS in the case of the UK. And then after that, filling the gap of that James couldn't be with us, we are going to share a video about palliative care, in which we will give you a demonstration how we created this interaction of our meetings and poetry. Then Ana Maria from Colombia she's a specialist in public health and works also in palliative care, and we are trying to develop some collaboration. So she is going to share with us some of her experience of working in Colombia, in the health system in Colombia, and as well she's going to illustrate palliative care. We thought that it would be interesting to have to contrast the UK with another country, in this case, Colombia. So we are expecting that you will enjoy the program. And I thought that probably the next slide, in order to start, I thought that I am sure nobody needs to your geographical skills to be refreshed, but just in case, I decided to present the mapa from North, Central, and South America, and then you can see Colombia in the context of the globe. And then in the right, you can see our neighbors, who are the countries that are our neighbors, Venezuela, Ecuador, Peru, Brazil, and Panama. And something to say about Colombia is that it's the first country that you find as you enter South America. Next. And then we thought that because a very special issue tonight is indigenous medicine, we decided to talk a bit about them. And next. This is the definition that the World Bank currently, in a report of 2018, has provided. Indigenous people are cultural, distinct societies and communities. The land on which they live and the natural resources they depend on are inextricably linked to their identities, the culture, the livelihoods, and physical and spiritual well-being. And this is something that you will see in a very compelling way listening to Leonor tonight. Next. Indigenous people are around 370 million and all over the world. They are in 90 countries, something that is quite surprising for some people to think that 90 countries is a high number. It's almost everywhere in the world. Next. Although they comprise 5% of the global population, they account for about 15% of the extreme poor. So very difficult conditions. Next. While indigenous peoples occupy or use a quarter of the world's surface area, they safeguard 80% of the world's remaining biodiversity. In this case, Colombia is one of the countries with a high level of biodiversity. Next. Indigenous people hold a vital ancestral knowledge and expertise on adapting, mitigating, and reducing climate disasters risk. So I think that this is a very brief picture in the situation of indigenous people in the world today. Thank you. And next, I think this is our introduction. Joe, yes. Yeah, thank you. Thank you. With this introduction, so we are going into the video that kindly Leonor prepared for us. But before that, I thought also that it will be very important because she's talking a lot about her land and her area in Colombia. And I thought that it will be interesting to share with you some pictures. In the program for tonight, we put some links. I am sure that probably people saw they opened and read some of the links. But we found some compelling pictures, and I hope this time they will work in my computer. Otherwise, I will be in trouble again.
We've put them in the chat as well. So if anybody wants to link on, they can look in the chat. Trina has them in the chat too, Carlos.
Okay, so let me see if I can find it because we were ready with that, which I cannot see now. Okay. Can people see my screen now?
Yes, we
Yes,
can.
that's perfect.
Okay, I am just going. The way how we are doing this is because we don't have a license to copy the pictures in our PowerPoint. So I have to go through the article, but I am just going to focus on the pictures because I think that the pictures are beautiful pictures and will allow to enjoy the presentation of Leonor. These are what the traditional doctors are called mamos, and she is going to talk about them in her presentation. She is going to talk about the environment and the landscape, and here you can get a glimpse of that. And these are the traditional clothes of them. A meeting. They are in the north of Colombia. It's an area called La Sierra Nevada de Santa Marta, which is a very pretty area because it's quite with high mountains, and the mountains go into the sea. And I expect to show you that in a minute. The water is another element that she is going to mention. And children. And as I was saying, they are in the north of Colombia, so the mountains go into the sea. And as you can appreciate, that is part of their environment. I suppose aspects of their daily life. And I thought that this will help you to imagine or to see better the area that they are, where they are located in Colombia. So the houses and the children. Yeah. Okay. With this brief introduction that I thought will allow you to enjoy Leonor's video, I will pass it to Jennifer, who is going to play the video for us.
Saludarte y desearte muchos éxitos en este evento. Al referirme al tema indígena, es imposible no referirse a temas esenciales, fundamentales, como son su espacio, su territorio, su cultura, su identidad. Esto encierra realmente la explicación para hablar de la salud de los pueblos indígenas. Los pueblos indígenas concebimos que la enfermedad, la salud y la solución de aplicar condiciones para salir de situaciones críticas como son las enfermedades, tiene que ver mucho, mucho con la posibilidad de una estabilidad social, territorial, económica, y tiene que ver precisamente con ese estado físico, mental que podemos tener las personas. Para los pueblos indígenas vamos mirando y vamos recorriendo una historia basada en las tradiciones indígenas. Las tradiciones indígenas no dejan de ser aquella relación que tenemos como personas con una identidad colectiva con la que nos relacionamos, y también la identidad que mantenemos con los espacios que ocupamos en los cerros, en las llanuras, en los páramos o en otros lugares, en donde consideramos las personas parte de la naturaleza, y la naturaleza es la esencia a la que pertenecemos. Eso efectivamente tenemos que llegar nos conduce a unas prácticas, y el equilibrio de esas prácticas relacionadas con esos espacios es lo que nos permite estar bien. Ahora, la pérdida de ese equilibrio de las personas con la naturaleza es lógicamente que nos conduce a mantener una situación en donde el desequilibrio se nota mucho en las enfermedades, en las condiciones que cambian y que son adversas a nuestra vida. Y esa adversidad tiene que ver exactamente con el comportamiento que como personas tenemos frente a lo que nos rodea, frente a la sociedad en donde nos movemos. Y estamos convencidos que es lo que produce la enfermedad en las personas. También la cultura arhuaca, por ejemplo, el tema de la enfermedad es un tema en donde somos receptivos, un cuerpo humano receptivo de cantidades de situaciones que enferman, pero que lo que más tiene que ver con de ser receptivos de enfermedades es las condiciones en las que vivimos, las condiciones en las que nos relacionamos, en las condiciones en las que dinamizamos la vida, y de acuerdo a eso estamos sanos o estamos enfermos. También creemos que las enfermedades no hacen parte del cuerpo. Creemos que pueden llegar al cuerpo y como un elemento que no es inherente realmente a la estructura de nuestro organismo, es curable. Y por eso consideramos que la salud depende, uno, del equilibrio entre las personas, otro, el equilibrio con la naturaleza y el medio donde nos movemos, y eso produce o enfermedad o salud. La salud tiene que ver mucho con la capacidad que tenemos nosotros de cumplir un orden que se establecen en las tradiciones, que pueden ser uno basado en plantas, en elementos naturales que podemos tener en nuestras tierras, o en el caso del pueblo arhuaco, en donde donde los mamos, que son las personas que manejan el conocimiento tradicional, pueden realmente equilibrarnos energéticamente y nosotros hacer las prácticas para lograr ese equilibrio energético. Y el equilibrio energético tiene que ver con la tierra que ocupamos, con el territorio tradicional que siempre hemos tenido ancestralmente, y ese territorio tiene lugares en donde los mamos pueden realmente recurrir para darnos la salud, darnos el poder eliminar las enfermedades o poder eliminar realmente todas aquellas cuestiones que son adversas psíquicamente, mentalmente también. Y por eso la tierra para nosotros es un elemento sagrado, en el sentido de que tiene la capacidad para mantenernos vivos y bien, y con dignidad como personas. Lo que hace posible la medicina tradicional, en el caso del pueblo arhuaco, tiene que ver con ese manejo, con esa estructura y ese conocimiento que, ligado a las tierras, ligado al territorio, hemos podido conservar lugares sagrados para cada uno de la energía que necesitamos quitarnos de nuestro cuerpo y también de fortalecer la energía positiva que necesitamos para estar bien. Hay otros pueblos que son mucho más sujetos a la botánica, a las plantas y todo esto. En el caso del pueblo arhuaco no es que tanto que seamos botánicos, la cultura arhuaca reconoce otra clase de medicina y todas son tradicionales, por supuesto, pero la medicina tradicional de los pueblos, de las culturas de la Sierra Nevada de Santa Marta, tiene que ver mucho más con los espacios que ocupamos, con los lugares que tenemos, con la energía que pues todos los días nos acompaña, que pueden emanar de lugares como las aguas, como las piedras, como las montañas. Y todo esto, ese campus que existe en todas partes, hace parte de tu salud o de tu enfermedad. Y esas prácticas es una forma de mantener nosotros un equilibrio entre el hombre y la naturaleza y entre las personas también. El equilibrio está entre la naturaleza, el universo y las personas. Afortunadamente no tenemos una visión en donde el hombre es superior a la naturaleza y es superior al universo y es superior a la tierra. Para nosotros hacemos parte de la naturaleza, de la tierra, y que nosotros tenemos que tener un tipo de comportamiento que ayude a ese equilibrio, que ese equilibrio es necesario no solamente como persona, sino que es un equilibrio que es comunitario, que es familiar, que es de la humanidad. Así creo yo que pueda resumir la cosmovisión de la salud de las culturas indígenas entre ellas la del pueblo Arhuaco, que corresponde realmente a la Sierra Nevada de Santa Marta, y que hay otros pueblos también que tenemos prácticas diferentes. Y esa visión de reconocer que somos somos parte de la naturaleza, nos lleva a un respeto también por el medio ambiente, por el agua, por conservarla, por tener nuestros manantiales limpios, y nos da una forma de estar, de tener unas costumbres, y nos permite realmente una identidad. Y eso es lo que nos da a nosotros la posibilidad del bienestar y la posibilidad de la salud. Para uno se enferma cuando interrumpe el equilibrio entre la naturaleza y la naturaleza y las personas como humanas. La salud se mantiene en la medida que mantenemos ese equilibrio entre nosotros y entre la naturaleza y el lugar en donde vivimos. Gracias.
I don't know if there are specific questions about Leonore's presentation, so people can put them in the chat. Otherwise, we will move to the next point in our agenda. That is my colleague, Radha. Okay, I think, thank you, Joe. Yeah, it was very kind of her to prepare this video for us, this special message. And it was a team effort to do the translation. And we hope we are making justice to what she was conveying. No questions. Someone is saying such a striking difference between this model of connection between people and natural environment and health and that of biomedicine. Yes, something to think about. Our next point in the agenda is our colleague from the Council of the Association, Radha Bhatt, and she is going to enlighten us about some issues about medical humanities, the NHS, and something very interesting. Radha, coming from India, she is going to talk about Ayurveda, which is a very indigenous system as well that belongs to India, probably one of the oldest in the world. And Radha is going to make that connection to continue with the thread of this of tonight. Radha?
Thank you, Carlos. Can everyone hear me?
Yes, we can hear you.
Okay. Good evening to everyone. I'm a consultant psychiatrist and a psychotherapist, and working in the NHS as well as private practice. And I'm a member of the Council of AMHH, which is an Association of Medical Humanities and Healthcare. Besides, I'm also an MPhil student at Berkeley College. Concerns are about what has happened to healthcare in the present.
Radha?
Yeah.
Oh, okay. So you are back.
Yeah.
Jennifer is suggesting if you stop the video and just use only the microphone, probably that will help.
Okay.
Okay.
Can you hear me now?
Yes, we can hear you.
Okay.
Okay.
I'll carry on. Yes. So I'll start from where we got cut off. Advent of heavily scientifically based education has deprived medical students from practicing and learning about humanities-based healthcare. Consultations are lean heavily towards disease-oriented questions, issuing prescriptions for targeting symptom relief, and not paying attention to what other ingredients are essential or desirable for healing, maintaining health, and a sense of well-being. Medical humanities have begun to make an impact on undergraduate medical education in the UK, and the relationship between the medical workforce and the humanities has grown stronger over the years. What is the relevance of medical humanities to healthcare, specifically to medicine? As a clinician and a practitioner in the mental health specialty, I see very little difference in applying biological knowledge and also learning about the patient's psychosocial, cultural, and socioeconomic aspects. The biopsychosocial practice is more prevalent in mental health specialty. However, generally, medical workforce is heavily biased towards science-based and evidence-based practice. The medical education is heavily biased towards scientific factual knowledge. History of medical education in the West shows us that Sir William Osler and Abraham Flexner were the most influential figures in changing the nature of medical education in the 19th century Britain. Osler was a great advocate of the apprenticeship model, where students were taught by the patient's bedside through interacting with the patient and learning by observing the medical educator examine and interact with the patient. This indirectly enables students to learn and value patient-centered care and absorb a wealth of knowledge not included in textbooks, such as showing compassion, communicating effectively, understanding the impact of culture, class, and spirituality on health and illness. In contrast, Abraham Flexner, an educationalist, said high quality medical education must include a strong foundation in sciences during preclinical years. From then on, biomedical sciences became part of the medical education as part of preclinical training, and the apprenticeship model continued during the clinical years. Even though the number of clinical years was increased subsequently, it remained proportionately small within the medical course. In the past couple of decades, further structural changes have been imposed on health service, resulting in a negative impact on the clinical practice. I will discuss these later in my talk. I would also like to refer to Jerome Lowenstein, who has written about how expansion of scientific knowledge in the field of molecular and cell biology, biophysics, and molecular genetics during the latter half of 20th century has resulted in a negative impact by inducing a learned insensitivity towards patients' needs. In medical languages, biological and scientific explanations supersede learning how to tune into patient's account of his experience of the illness and to learn skills needed to promote the healing process. The science of medicine gives us skills to observe, hear, and measure the subtleties of the signs and symptoms of the disease. The art of medicine is a major component in the healing process and involves application, personalization, and translation of the scientific knowledge in relation to the needs of each patient. Thinking biologically became deep-rooted in medical practices throughout the process of medical education. Learning the science of medicine teaches how to focus on the illness, but does not teach us adequately how to focus on the patient as a human being. Medical training has a language full of scientific and technologically sophisticated words to describe the minutiae of a disease. Whilst implementing scientific knowledge into practice during a clinical encounter, additional skills become essential, such as engaging with the patient's experience of the illness, curiosity about patient's psychosocial domain, culture, spirituality, and patient's own ideas about recovery, amongst others. Barely giving a diagnostic label and writing a prescription for treatment is not adequate. Can ancient systems of medicine and healthcare practices equip us in improving the healing practices and make in humanities-based practice. There are several indigenous systems of medicine across the world. The one I'm familiar with is the Ayurveda, which is the ancient Indian medical system. The name Ayurveda indicates knowledge of longevity, and it incorporates health promotion practices alongside healing of the disease. Treatment methods are personalized based on assessment of the patient's physical and mental constitution, and the treatments include natural herbal remedies, oils, dietetics, pursuit of a lifestyle to aim for balance of disturbed humors, and it includes practices based on spirituality. For example, chanting of Vedas and scriptures is important. Likewise, yoga practice, meditation, chanting Vedic hymns, pursuit of classical arts, for example, music, are full of knowledge and wisdom about their health promoting and therapeutic effects. These ancient practices are worth integrating into our healthcare. I'd like to emphasize at this point that I'm not talking about giving up scientific principles. Scientific principles behind medicine cannot be discarded. It's the science of medicine that gives us the skills in deductive logic while thinking of a diagnosis and specific treatment. Doctors become simply preoccupied in trying to reach a diagnosis and its cause. More often than not, they look for a causative agent, a virus, a trauma, or a chemical imbalance. Much broader thinking is essential in helping the healing process. How does a doctor begin to learn about the whole person who presents with a, say, broken leg, chest pain, or the one who developed panic attacks? Understanding the subtleties of patient's life is much more complex and needs time, capacity to reflect, use creative imagination to respond to questions other than the diagnosis and treatment. What could be the obstacles? We in the UK have been fortunate in having and benefiting from nationalized health service established in the post-war period in 1948. The NHS is the main organization for training doctors and other healthcare professionals. I've discussed earlier the impact of heavily science-based education on young doctors. Several other factors have impacted on health service and health education. Reduction of resources has led to a reduction in standards of care. Many factors, including austerity measures, increased demands due to demographic changes, breakdown of the public trust in healthcare professionals, particularly on doctors, excess workload and burnout are amongst some of the factors which have had a negative impact and reduced the standards of care. Time to talk to patients is essential in building up a therapeutic relationship, but increasing demands coupled with a drive for efficiency have resulted in limited time available for consultations in many medical specialties. Furthermore, patients fail to get the continuity of relationship with doctors because of the current work patterns, shift patterns of work in hospitals. Imposition of a protocol-driven, regulation-driven service combined with risk-averse strategies has resulted in clinical time to talk to patients encroached on by computer-based administrative tasks of various sorts. How should we include humanities-based healthcare in the current context? In the current system, focused efforts need to re-establish the depleted workforce. Far fewer healthcare practitioners are available and they become burdened with excess workload. It's also essential that we change medical education at the undergraduate level, changing the perspective of doctors who learn predominantly about scientific aspects about the disease and its treatment to become skilled in understanding the whole person is imperative. In this process, learning from literature, arts, philosophy, music, ancient texts will be highly relevant. One cannot underestimate the value of the wisdom embedded in Ayurveda, yoga, meditation, chanting, music, physical fitness, and balanced nutrition, cultivation of healthy lifestyles in the process of healing. Sadly, modern medical practice has become distanced from traditional healthcare beliefs. cultural perspectives of disease and health, and the significance of the arts and music in maintaining and promoting health, and the significance of spirituality, especially in health and illness. My views are that working with Association of Medical Humanities and Healthcare as a transdisciplinary body of professionals gives us hope of achieving the goal of firmly establishing humanities-based healthcare as a basic expected standard integrated with the ever-expanding scientific-based knowledge and wisdom we have in medicine. Thank you. I'll stop there.
Thank you, Radha.
Thanks.
Questions? I don't know if anybody in the audience has questions. You are, oh, yes, Joe? Your hand.
I was clapping.
Okay, thank you. Jennifer, there are some comments. Would you like to, in the chat? We cannot hear you.
Yes, I think it's really interesting that, and I think that this will also become clear with some of the other things that you're talking about too, that there's a kind of a theme about balance and maintaining a balance in different ways in relationships between different things. Radha, you spoke about, you know, the lack of time for the therapeutic relationship to happen. And I remember in talking with some friends that one of the things that came up was, you know, the fact that placebo is actually a really, really important thing in healing, an extremely important thing, but we can't actually get time to get to that sort of those kinds of things that are part of therapeutic relationship when the time is so short. It's almost impossible to grow a relationship with a doctor who is on a sort of a whirly cycle. So you get a different doctor every time, and you won't know the one you've met or seen. And yeah, and they've only got a very, very short time to see each patient. And that includes the time for walking, you know, from the waiting room and so forth, when you do get to see a doctor. It's a very difficult situation at the moment, I think. But it's also very true, this notion of, you know, there was a much more paternalistic type of attitude towards doctors and other healthcare workers too, who often are very influential in therapeutic relationship. So there's something really going very wrong that's out of balance, very much out of balance. And the in Ayurveda as well, also the relationship between your food, your mind, your body, the practices that of massage and all of the inside and outside that all knit together beautifully. There's something that where things have been separated off into different camps, and it's problematic. But I expect we'll talk about all those things later on
in the discussion. Jennifer, I was asking you if you could see
something
some of the comments in the chat.
Ah, okay. Something. Sorry, I thought I was doing my bit of filling in here.
Yeah, but thank you.
So, Deborah has said that she found it very interesting, Radha, that you have described the balance in Ayurvedic medicine in a similar way as the previous film was referring to balance.
And I don't know if one can generalize, but I will say that many indigenous medical systems will go for the same concept of balance, no? Keeping balance always is that. I think that is quite a, I don't know if a universal element.
Well, it's homeostasis as well in biomedical.
Yeah. Yeah.
Sorry, Radha's.
Are you reading the comments, Jennifer?
Well, Radha's disappeared, and I was just about to say there's some comments to say thank you, and she's not there for to be able to receive thanks. Then also there's Nikki has said that she thinks it's important to acknowledge that scientific and medical discourses have become so widespread and mainstream that another obstacle to humanities outlook is patient and family expectations. And as a clinician, that she often experiences resistance to perhaps more creative explanations of people's symptoms. That's very, again, that's a very interesting point. I think we'll probably come to a much more in-depth discussion at the end, but that's a bit like, that reminds me of something called obstacle to cure, you know, which can come up for people who are unwell, where there's something that's preventing the wellness as well. And sometimes there are creative explanations for what is happening to people. That's very important, as Joe has said.
I think I am aware of the time. It's 8:07. I think I hope everybody's okay with this, but I will suggest to go to the next presenter.
Yes.
And then if we have sufficient time, we will present the video and open the floor for discussion.
Yeah.
So I hope people agree with that. So thank you for that. So our next presenter will be Ana Maria Medina. She's an anthropologist and a public health specialist from La Universidad Javeriana in Colombia, Bogotá, Colombia. Ana Maria, welcome.
Thank you, Carlos.
Yes, you have been the lucky one tonight. We are in your presentation, so
okay,
that's fine.
So I'm going to turn off my video, so I hopefully we don't have problems with the data. I don't know how to say that, but I don't know why this doesn't change. No, not as luckiest. Hasn't changed, right? Yeah, okay.
Yes.
There it is. Okay. So just let me know if there's a problem with my audio or my video via WhatsApp. So I will be attending to that.
Okay, thank you.
Well, good evening to everyone, and thank you for the invitation. Thank you, Carlos. Thank you, Jennifer. I have been asked to outline my professional practice and introduce you to some of the complexities of the healthcare system using palliative care as an example. And as Carlos has already mentioned, I am an anthropologist. I am a family and community health specialist and a PhD in public health and recently thanatologist. So I just want to go back in my memories, and I remember questioning how public health policies ignore the sociocultural diversity of the country during my first seminar in public health policy evaluation in 2005. And by that time, the response by my teachers was that policies could not take into account diversity, but had to be general and non-specific. Although we have a political constitution that recognizes diversity and plurality, we have a cognitive dissonance that is still prevalent in the health field. Colombia is recognized as one of the more advanced countries in Latin America regarding public health policies, but there is a long distance between the paper and the practices, the daily life, as Carlos noticed at the beginning. Now, let me show you some basic elements of the Colombian universal health system. It's quite complex. I'm going to try to be very short explanations, but it's a structure around the affiliation of formal workers. So it's called a contributive regimen, and it has almost a contributive regimen which has almost 23 million people out of around 50 million people in the country. Sorry for that. Sorry for my. Anyway, Sorry for my English, but they have only like 23 million people in the contributive regimen, which are formally workers that contribute to the system. The other form of coverage is through subsidized system, where unemployed and very poor people are affiliated. And there we have around 25 million people. And additionally, there is a private insurance that covered that people that are affiliated with that system. Recently, with the statutory law in 2015, healthcare was recognized as a human right, which expands coverage for emergencies for all nationals and residents, people in our territory in the country, but only emergency services. Within the system, we have many institutions called EPS, and that they manage the money, and subcontract providers, which are the ones in the green line here, subcontract providers in the regions, in the faraway regions or all around the country. However, this coverage is not equitable for all regions in Colombia. In this graphic, you can see the different distribution of coverage. In purple, you may see the non-covered populations just in the middle, which are mostly indigenous and rural communities. In this kind of gray, the subsidized are more common in rural areas. You can see the more rural areas, Caquetá, Amazonas, Baupés, and Bichada. And in the bright blue is the contributed coverage concentrated in the main cities and urban areas, mainly in Bogotá and in Medellin, which are two cities I will be talking about a lot. So contributive patients go mainly to private institutions, while subsidized patients go to public institutions. Private institutions tend to have high complexity hospitals and palliative care that are concentrated in those big cities, such as Bogotá and Medellin. This is why people from rural areas and many indigenous people that may need the services may have to travel by river, airplane, or 12-hour bus ride to reach a high complexity institution, and why the poorest may not find a specialist near the living zone. I began working in San Ignacio Hospital in 2009 on an ethnographic project in emergency service. Through this work, we identified several cases related to palliative care and its complexities. For example, there was a case involving an Embera, which is an indigenous community, an Embera young indigenous boy with advanced bone cancer, who was brought to the hospital from the Putumayo region, one of the regions complexity services. The hospital team debate whether to perform palliative treatments involving amputation and chemotherapy, but the boy's family and community did not want him to undergo amputation as it will affect his quality of life. So the family and the community decide together that they will take care of the boy until his death in his own territory. However, officials from the Family Welfare Institute stopped the boy from being flown back to home and returned him to the hospital against his will and his family wishes, because they believe that life was the primary right to be defended. So the hospital has to play the expert card, the biomedical card, saying that there was no option under the biomedical treatment. The hospital won this legal battle, which took several months, but they did not have high complexity service in Putumayo region. And how he got access to pain medicine, or actually how he died, is not clear to me now. Currently, 15 years later, there is a shortage of pain medicine even in the main cities. So can you imagine what it was like for this young boy to try to access the pain medicine, living about 4 hours by river from the nearest town, So by the time and still now, diversity, social and economic conditions, and quality of life were not a consideration for end-of-life care of palliative care. Times has passed since then, and now that I work in a medical school and an aging institute, what I found most intriguing is that medical specialists who have to face death almost every day have no clue about it, except for how to determine it biologically speaking. In this slide, you can see which undergraduate programs teach about palliative care in Colombia. That's 4.0 programs in Colombia, and are in Antioquia, in Medellin, and Bogota programs. We have around 70 programs only in Bogota. So you can see how less programs, teach palliative care. The green lines indicate the main cities, of course. So there are regions, rural and native and the indigenous territories that have no medical education on this matter. In this route, where ideally, again, are services for individuals that range from promotion and prevention to palliative care all the way. But the main question here, is not the same private insurance for people in contributed service, private insurance or subsidized system. So the main question here are where, who, when, and how to tell the patient and the family about the need for palliative care. If we take the case of our young native boy, now it will take months until he or the family decide to go to the general practitioner, and he may be located 2 hours away by river and cost about $150 to get there. Since the general doctor cannot order special exams in our medical system, in our health system, he will be sent to the next level service that might be another 4 hours away, again by river. There, they may discover that the equipment necessary for he will be transferred again to Medellin or Bogota, which are 12 hours away by bus or 1 hour by plane. All with this delay in diagnosis, he will only have 2 options: either to die within a hospital in the city, far away from his family, outside of their community or territory, or die at home with difficult access to medical pain medicines, for example. He may, we call it tutela. I don't know if it has an equivalent in English, but excuse me for a moment. But this is a legal process that demands the service from the EAP. So the institution may say, I don't have a provider that far away. So you can imagine being at the end of life and having to go through a legal procedure to have a service that is supposed to be your right, to be a human right, with no access to internet, no money to pay a boat or a bus or transportation, with no language access, and with all these barriers in the access, with no resources for a dignified death. Many people will die before the legal process is resolved. On the other hand, a person with a private insurance will reach the specialist within 5 days. That happened with my mother. This patient may die at home 3 months or even less after their diagnosis. After their diagnosis, I'm sorry, but with all the necessary equipment and all the necessities covered. But even the specialists who first treat this patient, this private insured patient, will not know how to communicate end-of-life decisions, and will not have the information or the capacities to communicate properly with these patients. So finally, for example, oncologists, like in the case of my mother, will tell the families that they study medicine to fight death, not to take care of it. So it's their main problem is to fight death, not to take care of it. Finally, when the patient reaches palliative care, is often understood only as access to pain control. I think that's one of my main points. But the spiritual, emotional, and social care are usually neglected. And finally, once the patient dies, nobody, and I mean nobody, will take care of the family, since the system is individually based, not family based. So death, dying, and grief have become my topics of research. Not because I am expert in the topic, but rather as a question, a need that arises from medical students themselves, patients, and family who wonder about the incomprehensible. God, I'm sorry. I hope it was clear enough. My point.
It is. It is.
Mm-hmm.
Are you closing now?
Yes, I'm just going to see the reactions to what I just said.
You mean the chat?
Yes, if there are questions.
Oh, would you like? Okay.
Yes.
If people have questions or comments, they are welcome. You want to elaborate more, Jennifer?
Yeah, I think Ana Medina, I think I can hear the emotion in your voice. It's very, very shocking, isn't it? There's sort of, it's almost like a dehumanization in terms of taking people away from their families and communities, and yet, and it's either one thing or another thing, but you can't have a relationship between both, because there isn't the care in place where the families are and where people live, and the disparities between people who have and people who don't are at extremes. We have extremes in this country, but your extremes are much bigger extremes.
Yeah.
Yes. Thank you. Yes, no, go ahead, please.
It's just in the chats, people are also asking if we could see the slide with the quotes from the medical students.
Yes, of course. I have quotes from medical students and also from patients and family members. So, like the general practitioner says, I cannot order him what he needs, because I have to send him to the specialist. In our system, only the specialist can order specialist services. So it may take 6 months to reach a specialist. They usually don't know what they happen to their patients. They don't know if they have palliative care or not at home. They send them home to die, but they don't know in which conditions they die. They have violence and insecurity problems. They don't move to some places because it's a dangerous place. And actually, they find very disappointed that they don't know if their work they're doing in the hospital helps people. I mean, they know they save lives, but they don't know if they help people and in the quality of life. So I think I work with these medical students and doctors. So I think one important thing is to give them an historical perspective and socio-economical understanding of what is going on in our country. So yes, and this is what most of the patients have said in the interviews we made, in the research we made. They have to decide if they use or not. I don't know if the name in English is the same, but the equipment for breathing when you have,
It is
Yes, they have to disconnect it because the electric bill, the energy bill is too high. So they have to decide either to disconnect it or pay. Usually they disconnect it. They can stay 15 days, 2 months in the hospital because there is no palliative care at home. So they have to die at home because there is no other option. And
Ana Maria,
yes.
There are 2 comments that I find. Brigitte, would you like to elaborate further on your comment?
Yes, so hello everyone. Sorry, I better get my face on the screen. So I think we're dealing with a number of different things here, and I think it's important that we make sure that we balance that Western medicine may have something to offer in care and knowledge base from a scientific perspective. What we somehow got to translate as well is that into local and embodied experiences, which is always true. It's true in England. It's true even more so in cultures which have very different attitudes to science and connection. And you can even see that difference in the USA, you know, in relation to COVID and vaccination. How do you deal with the non-vaccinated, etc.? And this has created a lot of dialogue. By the same token, we mustn't forget that palliative care is actually one of the last specialties to emerge from scientific medicine. It was very much a center of medicine historically, how you looked after people, and then it became a religious issue. Subsequently, with Dame Cicely Saunders, England was the first country that really made it a speciality. And even when I went to work in Belgium in the early 90s, palliative care was not at that point available in many European countries. And the way we did it in England was considered extreme and possibly lethal and bad medicine. That's no longer the case. But if it's not that long ago, this is about 30 years ago. So it is the last thing that Western medicine tends to adopt. So that's the second thing about palliative care. And I think it takes great assurance and knowledge to mediate your scientific background into alternatives which are slightly outside the norm in order to translate that into something locally acceptable. Obviously, if you work in a locality, you need to start to know that, and that's important. And I find that a problem. I give opinions to Médecins Sans Frontières, to remote hospitals in rural areas that are very, very poor, very limited resources. And I sometimes see colleagues giving opinions about rare, untreatable conditions, even in Europe, and just think that doesn't help anyone. Let's work with what we've got, let's be pragmatic, and let's make this as good care as possible for the circumstances people are in. We may also want to improve care and resource allocation to be fairer internationally. But the whole issue is very complex, it seems to me. Sorry, I've ranted on.
Yes, Brigitte, thank you. Two things about, I just want to remind people of one of the best psychotherapists in India said in one of his books that the West is not a geographical area, but a mindset. So when we are talking about the West, I think that we are talking about certain ways of doing things. And I don't think that we are here ignoring the role of science. I think that we acknowledge the role of science, but I suppose we are pointing out to some elements that need to be integrated further. And I think that you are right about the history of palliative care. What is very interesting is that for me, palliative care brings some elements that are quite revolutionary to medicine in general. For example, the hospice as a space that is being demedicalized because it's a place in which you can go and die quite in a relaxed way. You don't need all the equipment. You don't need intensive care. And I think that I find that absolutely powerful. Absolutely. Also, the notion of Cicely Saunders of care, is how you add life to your last days of life, rather than the place in which you go to die. There are many things to explore, and I really believe that palliative care is quite revolutionary, that can show a lot of lights into science, but also humanities. Unfortunately, what I see is that all the research in palliative care is about pain care and is very biomedical research. And there is only little social and anthropological and cultural research on palliative care so far.
That's absolutely relevant. Yeah.
There is another, sorry, yeah.
And I was going to say as well, I can't remember who said it, but I think it was the person who wrote Medical Nemesis who said that we steal time from patients when we get them to have tests, particularly if the tests are not needed. And that is all the more relevant towards the end of life when time is scarce. It's all the more relevant when people have to travel hours down the river and stay overnight in places when they don't have the resources to do so. So these ideas of totally thinking through the situation are key.
Yeah. There is another comment to close. I think what we are going to do, because I am aware of the time, we are going to circulate the link for the LabCell video in which we are giving a bit of background about a palliative project that I had for 5 years related to the needs of minorities here in the southeast of England. So in that project, we experimented with pictograms, and people will see in the video what was the idea of the pictograms to try to encapsulate some general messages and allow some discussions about death and dying. And the second point was the poetry, as I mentioned at the beginning, to absolutely help to manage the nuances and the tensions and the irritations that people get when we have to talk about death. Like if Deborah has some questions about Colombia and if the family is involved or not, and two things very ironic. Colombia is among the few countries in the South that has approved euthanasia, when in fact it's not here in the UK. I think that this is quite, and I think Jennifer was talking about the how the problems are similar, but of course more exaggerated in places that have less resources, and that is the case. But ironically, we have, I suppose, if I have a terminal disease, I can request. Of course, as Ana Maria said, it's difficult. The law is trying to create obstacles, but I can demand the euthanasia, I mean, the right to die. As I am saying, that is something that we don't have in the UK. And the other thing that it seems to me, and Ana Maria, you correct me if I am right, the family is involved. The family is involved in I suppose if a patient is facing the end of life, the family is involved. Is that the case?
Not really. In our hospital, it is, because we have those policies, but not in the health system. I mean, now the grief is covered by the health system, and even as we have discussed, like we have families that even don't have the money to the burial of their families. So after death, there are a lot of other problems that the families has to handle, and there is no policy that cover any of those problems that are related to death, to relatives,
that's what I was asking about. That's actually what I was asking about. Is that seemed to me very ironic that in the UK we're not so focused on the family as a unit generally, but actually with palliative care, if you're lucky enough to have it, actually the care to the family is extraordinary. And so it just struck me when you said that the family was completely ignored and left to sort of deal with that on their own, that there was something really, really odd there. And there's different practices at such a point. But it was, anyway, I think it's going to be really important research. I'd love to hear more about it.
Yes.
Thank you.
More questions, comments? I think thank you very much to all the presenters, to all of you for being patient and accepting of our technological limitations, despite the fact that we spent 3 hours this afternoon preparing everything. Things played at the end in a not nice way. Jennifer, would you like to say?
Well, I was just thinking, I mean, I know we need to finish now as well, but it seems to me that the thing that we're missing the most at AMHH, we will get some of at the conference that we're having, which Deborah is putting together beautifully, is the opportunity to actually sit and chat to each other about some of these. It's tricky when there are questions in the chat, but there was a lot of richness here tonight, and there's a lot of depth. And it seems to me those conversations that we usually manage to have sitting around with I don't know, sitting around the table, a cup of coffee or a glass of wine in the pub or whatever, is one of the things that that develops the depth of thinking in any of these areas. And that's something that I wish was easier online, and I'm not quite sure how we can find a way to try to manage that a bit better, but I think it's something that we should think about. The second thing is that I want to absolutely thank Carlos and Rada for putting together tonight's program, to thank Anna Maria also for coming. That was absolutely fascinating. And to thank Trina and Paula for helping us with our tech, and also Joe for stepping in. And just once again to say, we did prepare, we really did, but it all did go a bit pear-shaped.
And I also want to thank, my family, my sister and my niece got involved in the translation and putting together the video. Thank you all.
Thank you, everybody.
Thank you. Thank you.
Good night.
Night.
All the best.
Thank you very much. Thank you. Good night.